Good afternoon, everyone, and a very warm welcome to Stewarts Soundbites. We are on episode 33 today. And today I'm absolutely delighted to be joined by Professor Jon Stone. We have a really interesting topic today, and something that lots of you have asked me about. So here you go. We are delivering. Well, Professor Stone is delivering. I am not doing anything meaningful. But by way of very brief introduction, Professor Stone is a consultant neurologist and an honorary professor in neurology for the University of Edinburgh. Now, Professor Stone, I'm sure actually that you don't need that much of an introduction because you're an expert in this field in functional neurological disorders. So first of all, welcome, Jon. Thank you so much for joining us. And because we have so little time, I'm just going to dive in and I'm going to bring us right back to basics, Jon. So forgive my first question, which is, can you just explain to us what FND is and what are the symptoms for people to look out for? So I'm thinking rehab professionals, case managers, what are we looking out for?
Yeah. So FND is functional neurological disorder. It describes one of the commonest conditions that we see in neurology, although it's been really quite hidden. It really describes neurological symptoms of motor and sensory function. So we're talking here about symptoms like paralysis, tremor, seizures, numbness, blindness. It's not a description for all functional disorders or all symptoms like pain and fatigue. And we define it really, they are genuinely experienced conditions, obviously, related to abnormal nervous system functioning. And the key thing about them is that you can make a positive diagnosis based on findings that show that the nervous system is working okay at some points, but at other times is clearly not. So that's them in a nutshell.
Okay. And you've mentioned diagnosis there, and I wanted to kind of dig into that a little bit, if I may, Jon, because there's been some discussion about FND and the diagnosis of FND being largely one of exclusion, I think, previously. And my understanding is that that's a pretty outdated notion now, Jon, that you have all these symptoms and you can't reconcile them with anything, so you come to the conclusion that it must be FND because it doesn't match anything else. But are we able to positively diagnose it now, and if so, how does that happen?
Yeah, so there's been a big change in the field really in the last 15 years or so. For perhaps 100 years or so, we've been stuck with a model for these kinds of disorders where and that's actually how it was defined in DSM, was people coming along with a symptom like paralysis, a doctor saying, oh, have you been stressed? Say, oh, you've been stressed. The test being normal, and then say, oh, it must be FND. We've really turned that on its head now, I think. To make it this diagnosis, it's a rule-in diagnosis. It's not a diagnosis of exclusion. And you're looking for clear positive features that are typical for FND. So this is not about saying to somebody, oh, well, your scan's normal, you've got FND. That's not how you make it. If that's how the diagnosis has been made, it's bad medicine usually. Right. So there are characteristic sort of presentations and the clusterings of symptoms, and the way people describe their paralysis or their seizures is often very typical. But when you come to examine the patient, you might be looking for something like a Hoover's sign, where someone has great difficulty keeping their foot on the ground when they're trying to do it. The more they try, the worse it gets. But when you get them to lift up their other leg, just transiently, it comes back to normal. So that shows you that they've got a disorder of voluntary movement, but the automatic movement is okay. And we have similar tests for tremor. We have typical features of functional seizures. So very much a diagnosis of inclusion now. Okay. And that's been transformative, I think, for the field and people understanding this is a medical condition just like any other, really.
Yeah, for sure. And that's interesting then, Jon, because obviously there are neurologists who would diagnose the condition. You'd go to see a neurologist, but is it something that our rehab professionals who might be watching this webinar can do with clients that they may suspect of these sorts of symptoms? There's simple tests like you just mentioned that they could do just at home with their clients.
Yeah, I mean, you've got to be careful. Making, neurological diagnosis is difficult. There are many pitfalls in both directions. One of the main pitfalls is that just because you find signs of FND doesn't mean that the patient may have another neurological condition as well. So patients with FND often have multiple issues.
Yeah.
I think generally speaking, an FND should be diagnosed by somebody with expertise in making neurological diagnoses. It doesn't have to be a neurologist, but someone with expertise.
Yeah.
However, I do think it really helps if the whole multidisciplinary team understand some of these signs and can do them and share them, particularly after the diagnosis, to help people understand them. So very simple things like if someone's got a tremor of their hand, you can just get them to copy a movement that you make, speed it up, and then slow it down. And you'll often see the tremor change in a way that's typical of FND. Those sorts of small things can really help everyone be on the same page.
Yeah, and it's a starting point, isn't it? Anyway, John, as you say, before you have that kind of neurological diagnosis or someone experienced in neurology. And I want to talk a little bit about the causes of FND. We know it's a neurological condition, but can you tell us specifically what causes FND? And I suppose very importantly for the people that'll be watching this session, John, how can it be treated?
Yeah, well, it's a disorder really, I think, that is best framed at the interface between neurology and psychiatry. So it's been characterized as a purely psychiatric condition. It's going on in the brain, but it's probably a bit misleading to say it's entirely neurological either. In fact, it challenges our ideas of what is a brain condition anyway. It's definitely a brain condition. The causes are many. You can't pin them down to one thing. So previously we've been stuck with this rather narrow model, which is that all FND is caused by stress somehow that's converted into a symptom. That was Freud's idea. And that's why it's been called conversion disorder. I do meet people where that's true, but very much the minority. And I think we've now got a much broader view of what causes it, which is similar to things like what causes migraine, what causes irritable bowel syndrome. It's probably a little bit genetic. Physical triggers and physical illnesses are very important. In fact, they knew this 100 years ago, but it's sort of lost knowledge. So infections, injuries, things like panic attacks out of the blue will suddenly cause it. And that's, of course, why there is, you do meet patients with FND in medical legal scenarios after injury. So any kind of new sensory or surprising experience can be enough, it seems, for some people to trigger this problem where the brain starts to behave in a different way and creates these sort of abnormal programs that cause these symptoms.
It's really fascinating, and as you say, it's really common, isn't it? I mean, it's more common than we know.
Yeah, so we did quite a few years ago now. I did some studies with my colleague Alan Carson, which showed it was the second commonest reason to see a neurologist. That was functional disorders in general. That's after headache, and so that includes actually quite a range of functional disorders, which perhaps you wouldn't specifically call FND, but still we're seeing about at least 6% of new outpatients have these much more severe and obvious problems like paralysis and seizures, but it's not out there on television or media, although things are changing slowly. But yeah, it's as common as MS or all people with movement disorders, for example.
Yeah, and is treatment developing for it, John? Is there ongoing research? I mean, are there new ways to treat it?
So again, I think another really exciting way that the field has developed is to have a broader sort of multidisciplinary approach to treatment. A lot of it's been about rediscovering approaches to treatment from a long time ago, from the 19th century. So, for example, for people with walking problems or tremor, some of the most exciting data on treatment comes from physiotherapy that's focused specifically on FND. So, for example, if you have a stroke, you might ask someone to think really hard about their limbs when they're doing treatment. But in FND, that tends to make things worse. So we've realized you have to do things differently. You have to be very transparent about the way that these diagnostic tests and distraction can change and improve symptoms to promote automatic movement. So some very promising data from randomized trials for physio, for motor disorders. I think good data to support the use of things like psychotherapy, including CBT for functional seizures. So I think we're getting to the point, hopefully, where people do recognize that these conditions do have an evidence base for treatment. We need to recognize them and try and help people get that treatment.
Yeah. And I know that you've touched on this already, Jon, so forgive me for going back over, but I do think it's an important point, the one that you raised in relation to this kind of psychological aspect of this and the interplay between FND and psychological stress. And I wanted to ask you whether is psychological stress always present in somebody with FND, and is FND now a new term for conversion disorder? Is there a difference?
Yeah. Well, it is, so it is a new term for that disorder, but the way we're thinking about the disorder has changed, so that psychological stress is not always present. And many patients will, there's been a tendency in the past to say, well, the person must have stress, you just haven't looked hard enough, or the patient's repressing the stress, and then the patient's in a position where they can't possibly, there's sort of no escape from that, because But I think studies have shown that stress is just one risk factor. It's a very important risk factor. It's very common. And you do see quite high frequencies of psychological comorbidity, things like particularly anxiety disorders, panic, post-traumatic stress, particularly relevant in the sort of clients your viewers may be seeing. So it is important, and you need to formulate that with the symptoms to see how are they interacting with each other. And they often are. But it's a functional disorder is not a synonym for a psychological disorder. It's a condition in its own right. It's almost like another category of condition that we need to get used to talking about.
Yeah, and that's why doing this sort of thing I just think is so important, because there's so much ongoing research and information emerging, isn't there, Jon? And I think that the way we think about FND has changed significantly in the last little while, and I think this is a good time just to mention that Jon, you have an amazing, if I may say so, website that I'll put the link to at the end of this session so everyone can access it, because there's a huge amount of information on there and research and data and everything that people can have access to. And I know that that's helped loads of people, Jon, with symptoms that have referred to that website. So I'll make that available. But anyway, going back to my questions, I wanted to talk a little bit very briefly about the overlap between FND and other diagnoses. So chronic regional pain syndrome and post-concussion syndrome. Do they often go hand in hand, those things?
Yeah, so I think what's happened, hopefully, is that as FND people start to realize it's a genuine disorder, and it's going to take a long time, but if we can reduce the stigma and misunderstandings about it, it opens up very much more interesting conversations about these other symptom syndromes and which people have struggled with. So, for example, complex regional pain syndrome, we've written a paper on that, looking at the overlap between FND and CRPS. And showing that it's been known really for a long time that the motor and sensory features of CRPS are the same as FND. They're clinically, you see a Hoover sign, you see functional tremor, but that doesn't mean that CRPS has a biology, but so does FND, and so the conversation hopefully is different. And I think it then opens up interesting questions like, can treatments that have been developed for CRPS help people with FND? Can FND treatments and the sort of things we're discovering about physio help CRPS? I think they might be able to. Similarly for post-concussion syndrome, which is, I think, not a terribly helpful term because it hides lots of differences and lots of different symptoms and problems. But the condition triple PD, which is persistent postural perceptual dizziness, is a type of functional disorder, really part of FND, I would argue. Functional cognitive disorders we're also doing research on, which again occur a lot of post-concussion syndrome. So I think being more specific about these things make more clear diagnoses, pathways for treatment for individual symptoms could really be helpful.
Yeah. And it's a really interesting discussion to have, Jon, as you say, because well, the type of discussions that we're having around these issues has changed so much, which is important. And it presents unique problems, doesn't it, for treating rehab teams, I suppose, in doing, actively helping their clients, and for us as legal professionals as well, it poses its own unique issues. So the problems are so far reaching, and I hope that this webinar just kind of gets thinking about it and use as a springboard to take action if it's necessary in their own clients. And the very last thing I want to ask you, because as always we're running out of time, is about prognosis. And that's something that I've been specifically requested today to ask you about, Jon, so no pressure. But is there a prognosis for people with FND?
Yeah, well, we've done some of the studies here in Edinburgh. The prognosis, we did a study, for example, of looking over 14 years at people with FND causing limb weakness. The prognosis varies hugely. So you see about 1 in 5 patients where it resolves and essentially it's gone. You see about 2 in 5 patients where it is improved, sometimes significantly to the point where it's really just a background issue. But there's still a lot of patients between 2 and 5 and 3 out of 5 who are where it's really the same or worse. And we shouldn't be thinking people sometimes have a misconception. It's a functional disorder. It ought to get better. It doesn't sometimes. These are often chronically disabling disorders. And unfortunately, particularly, I have to say, in a medical legal scenario, the whole environment of that is often not conducive to treatment for all sorts of reasons, which I'm sure everyone's familiar with. But that's not to say, I have seen people improve during a medical legal case, but sometimes it's better, it's so stressful that it's better to wait until it's over, but it varies from person to person.
Yeah. Well, thank you ever so much, Jon. That has been so useful and really, really very interesting. As I said, I'm going to put links to your website, to some articles, and to your Twitter account, which has some brilliant information on there as well, at the end of this presentation. But as always, we're out of time, so there's nothing for me to do but say thank you ever so much, Jon. It's very much appreciated.
No, thank you, and it's nice to be able to have this opportunity to raise awareness of FND.
Good. Thank you so much, Jon.
Yeah, thank you.